Good evening. This is our legal notice. All content shared, displayed, or otherwise presented during this meeting, including but not limited to sorority manuals, ceremonial rituals, and other materials that contain Delta's trademarks, copyrights, and any other intellectual property, is owned and controlled by Delta Sigma Theta Sorority Incorporated and is protected by law. Participants shall not photograph, video record, screen capture, or otherwise copy Delta materials to modify or reproduce for personal or third-party use. Participant further understands, agrees, and acknowledges to be solely liable for any damages in law or in equity resulting from violation of applicable laws and shall be subject to disciplinary action according to the Member Code of Conduct and any other related agreement. Our emergency response message. I hope that you are all healthy and safe in your own places and spaces during this virtual meeting. Please identify 2 exits in your current location. We must always be sure that there are 2 exits available to us in case of the need for an emergency evacuation. Also, during the COVID-19 pandemic, please remember to wear your mask, wash your hands, and always walk and stand 6 feet apart from others. Thank you.
Good evening. I'm Crystal Bostic, serving as the first Vice President of the Wilmington, Delaware Alumni Chapter and the Chair of Program Planning and Development Committee. Welcome to the webinar for Understanding Genetic Testing for Cancer Risk and Prevention, hosted by the Wilmington, Delaware Alumni Chapter of Delta Sigma Theta Sorority Incorporated. Since the founding in 1913, Delta Sigma Theta Sorority has distinguished itself as a public service organization that confronts the challenges of African Americans and hence all Americans. Over the years, a wide range of programs addressing educational development, physical and mental health, international awareness and involvement, and social justice remain monumental of Delta's 5-point programmatic thrust. The Wilmington, Delaware Alumni Chapter was chartered in 1949 and has been serving the greater Newcastle County, Delaware for nearly 75 years. The mission for this biennial is to engage, evolve, excite our members and our communities with impactful programs to ensure a better tomorrow. On behalf of our chapter president, Ronette A. Finch, and the 300 members of the Wilmington, Delaware Alumni Chapter, we invite you to learn and grow with us this evening as we discuss genetic testing for cancer risk and prevention. Before we begin, please take a moment to read and respond to a quick poll question. Please present the poll question. Okay, thank you. At this time, please close out the results. All right. Now I have the honor and pleasure to introduce the moderator, Dr. Marshall Lee McCall. Dr. Marshall Lee McCall is a board-certified family medicine physician, faculty member, and the director of the Harrington Trust at Christiana Care's Institute for Research on Equity and Community Health. Dr. Lee McCall's role supports efforts to strengthen the community partnerships, trainees from underrepresented backgrounds in medicine, and develop new models of patient-centered healthcare that address the social determinants of health. Prior to joining Christiana Care, Dr. Lee McCall served as medical officer at the Health Resources and Services Administration, where she also served as branch chief for graduate medical education. Dr. Lee McCall completed her undergraduate training at Tougaloo College and went to obtain a medical degree with a concentration in advocacy and activism from Brown Medical School. She completed family medicine residency training at the University of Maryland Medical Center. Following residency, Dr. Lee McCall was chosen as a Commonwealth Fund Fellow in Minority Health Policy and obtained a Master of Public Health with a concentration in Healthcare Management and a Policy from Harvard Medical School. In her free time, Dr. Lee McCall serves as a member of Brown University's Advisory Council on Diversity and Brown University's Advisory Council on Relations with Tougaloo College. She is a proud member of the Wilmington Alumni Chapter of Delta Sigma Theta Sorority Incorporated and has served as co-chair of the Physical and Mental Health Committee. She is a health contributor to the Metropolitan Wilmington Urban League, a board member of the Communities in Schools organization. She has served as the Young Physician Coordinator and the Vice President of the First State Chapter, Delaware, of the National Medical Association. Among her many honors, Dr. Lee McCall was recently awarded the 2021 Brown Medical School's Junior Alumni Award of Excellence in Diversity, and in 2021 National Medical Association Young Physicians Award, and in 2021 recognized by the Delaware Business Times for Top 40 Under 40, and more recently of 2022 Harlem Fine Arts African Americans in Medicine Award. Soars and guests, please help me welcome the moderator for tonight, Dr. Marshall Lee McCall, to this virtual environment. Thank you.
Good evening, good evening. It is such an honor and pleasure to be with you today. Every time I hear my bio, I get a little squirmish. So thank you for sharing all of that. But most importantly, I'm here today as a proud member of the Wilmington Alumni Chapter of Delta Sigma Theta Sorority Incorporated. Across the United States, African American women are dying at alarming rates from breast cancer. The breast cancer mortality rate is significantly higher for African American women than white women. Research has shown that part of this disparity is that Black women are often less likely to be referred for genetic counseling and testing, suggesting that there are racial disparities in how some doctors refer patients for those services and awareness among patients. We know that genetic counseling and testing can identify those at risk for developing cancer and other preventable diseases. It has also been shown to be able to be used to personalize cancer prevention for individual patients, and it can guide treatment in those who have hereditary breast cancer caused by gene mutations. We have a fantastic speaker for today's webinar. I am so excited to hear from my colleague, Kendra Flores, who will provide us with resources and information to be better informed about genetic testing so that you and I can be better informed and serve as advocates for our health and the well-being of our loved ones. Kendra Flores is a senior genetic counselor at the Christiana Care's Helen F. Graham Cancer Center and Research Institute. She is a proud New York native, and completed her undergraduate coursework at Syracuse University and obtained her master's degree in genetic counseling from Howard University. She has over 10 years of clinical experience in prenatal, general, and oncology genetic counseling. She holds a faculty appointment at the Thomas Jefferson Graduate Program in Genetic Counseling. At Christiana Care, Kendra works in a high-volume clinic providing risk assessment, support, and facilitating the genetic testing of individuals with a personal and family history of cancer. In her free time, Kendra enjoys photography and spending time with her husband and 2 young children. Kendra, on behalf of the Wilmington Alumni Chapter of Delta Sigma Theta Sorority Incorporated, thank you so much for joining us today. And I'm super excited to learn some great information from your presentation today. Thank you.
Hi, everyone. I'm very, very honored to be here today. Thank you so much for inviting me. I'm going to start sharing my screen and get right into the presentation. Again, thank you so, so much for the warm welcome. All right. So, without further ado, I'd like to talk a little bit about genetics, especially how that genetic testing can relate back to a person's risk to develop breast cancer. In order to talk about that, I first need to define some terms, and the first and most important term that we need to define is hereditary cancer. What exactly does someone mean when they say hereditary cancer? So, I tend to think about cancer in general fitting into one of these 3 parts of a pie chart. And the most common part of the pie chart is sporadic cancer. The vast majority of cancers that we'll treat at the Helen F. Graham Cancer Center happen by just chance, age, random occurrence, something that happened because of a known exposure, like, for example, lung cancer in a smoker or skin cancer in an area that's exposed to the sun, or just by age. We are circling around a giant ball of fission, and that radiation is a risk factor for DNA damage. So the phrase that we have to say is, even if you're doing everything right, even if you're eating perfectly and exercising and doing all the things right, sometimes it is just a matter of how many times we've circled the sun. As we age, cancer is always going to be a risk. It's important to note, though, that part of the reason why primary care doctors and OBGYNs take an expressive point in taking a family history is because we do know that your family history of cancer can give us insight into what cancers are more likely. And as we look at that family history, we can say certain cancers might be at a higher risk than other cancers. So when it's just simply a family history, we call that familial. And that's just the idea, probably not anything new, that a woman whose mom had breast cancer has a higher risk of cancer than a woman whose mom had not had that mother had not had breast cancer. So it's not to say that any genetic testing had been done, but simply that having a family history of a particular cancer modestly increases your risk for that particular cancer. What I focus on, my bread and butter, is hereditary cancer. And I want to point out very intently that only 10% of cancers are hereditary. The vast majority of cancers do not fall into hereditary cancer. But when we do see hereditary cancer, it's very, very important to identify. In hereditary cancer, a single gene, a single mutation within a gene is passing down from generation to generation. And it's that singular mutation that is responsible for not just a modest increase, but sometimes a dramatic increased risk of cancer. And it's individuals that have hereditary cancer that would benefit the most from getting hereditary cancer genetic testing and possibly getting increased screening because of it. So I'm not telling you anything you don't already know when I say that environment and cancer are related. We know that there are things, both the things that we know we're exposed to, as well as the things we don't know that we're exposed to, that do increase a person's risk to develop cancer. But to complicate it a little further, there are things called tumor suppressor genes. These are genes that their job in our body is to do nothing but stop you from getting cancer. So if, for example, ionizing radiation were to damage your skin and you would have otherwise developed skin cancer, these genes go in there and correct that damage in some way and stop you from getting cancer. You get a copy of this gene from your mom and a copy of this gene from your dad. So we always have 2 copies of every gene, one from mom and one from dad. Now, when cancer at the cellular level is looked at, all cancer is genetic. No matter what the cancer is, no matter what the family history is, in the cell, in that tumor cell, there's always been damage to those protector genes, but usually those happen over time and in years of exposure. It's why most cancers don't happen under the age of 50. Most cancers take many, many years of repeated exposure before cancer happens, and that happens over time. Compare that to hereditary cancer, where instead of having two copies, one from mom and one from dad, you only have one functioning copy. And the second copy that you have was broken. It was mutated. There was something different or not working about it from the first place. And so it made you more likely to get cancer. So in hereditary cancer, once over a smaller period of time, you damage that one remaining copy, you're left there able to get cancer. You're now more susceptible and you may develop cancer. I have an exercise that I hope to use to illustrate this. And my hope here is that even though this is a listen-only webinar, that you could jump into the chat when this applies to you so that we can use this as a learning opportunity. So here's the exercise together. In this exercise, every person here in the webinar is going to represent one cell, and collectively we're going to make up all the cells that make up a breast. And so each one of us will have two protective genes, two tumor suppressor genes that we will use to protect ourselves from developing cancer. So for our exercise, we'll have our left hand and we'll have our right hand. And these two hands will be the two protectors against cancer. Now, as time goes on in the exercise, each different round, damage can be onset to these protector genes. So if we have damage, if the thing that I say applies to you, you raise that hand and you've lost the protection of that hand. And then if the other one gets damaged, you raise that hand. And once both hands are raised, you're without any protection. So next, I'm going to list off characteristics. You listen to the characteristics, and if that characteristic applies to you, raise one hand there at home. And then keep listening, and if a second characteristic applies to you, raise that second hand. And then once you've raised two hands, I would ask you to please type the word cancer into the Q&A. And the moderators are going to listen for that Q&A statement to see when cancer occurs, and they'll unmute and let me know when cancer occurs. Okay? So in this first exercise, everybody has two hands at their disposal. This is sporadic cancer. So everybody has the copy from mom and the copy from dad working just fine. Please raise your hand if you drive a green SUV. Please raise your hand if you have ever lived in the state of California. Please raise your hand if your first name has 6 letters in it. Please raise your hand.
Cancer.
Cancer. Okay. So let's say, so we'll go back. That took 3 decades. So let's say at the age of 18, you will do 28, 29, or sorry, so 28, 38, 48. This cancer happened at 48. Now, let's go on to the next hereditary exercise. In this exercise, everybody has only one hand. So one hand is not operational. It cannot be raised. So listen to the prompts and let me know if cancer occurs. Raise your hand if you drive a white car. Raise your hand if you have a grandchild.
Cancer.
Cancer. So sometimes in groups, there's a little bit more space between these two, but my hope here to illustrate with this small activity here is saying that if you think of every prompt, everything that could or could not apply to you, think about this as we can't do anything but be exposed to some things on this earth. And so there are going to be things that damage our DNA by just pure exposure. And how many protective copies of this gene actually results in how likely it is for not only cancer to happen, but for cancer to happen earlier in life. So up here at the top, you're seeing from birth, this sporadic cancer individual has 2 copies. And let's say it takes 40 years for the first hit to occur. And then maybe another 20, 25 years for the second hit to occur. And that's where cancer occurs at 65, almost 70. That's the typical onset age for most cancers. Comparatively, down here on the bottom row, the individual is born with one broken from birth. So when the first hit occurs at age 40, that's where we're seeing breast cancer arise at the age of only 40. And that is why when we think about hereditary cancer, a young age at diagnosis is the hallmark feature. What I'm looking for the most when I'm taking a family history is, to the best of someone's ability, to estimate, was grandma diagnosed in her 40s, her 50s, or her 60s? Because if to your best ability you think that that was under the age of 50, that makes us more worried that it might be hereditary cancer. So I just talked about family history. Let's focus a lot more on family history. Why do your doctors care so much about your family history? Why do I, as a genetic counselor, take such a great deal of time to obtain a family history and interpret it? So hypothetically, when you're thinking about your family history, you're not thinking about what people passed away of or what people's diagnoses are. You're thinking about your kids and the things that your kids like, and your brothers and sisters, and the things that the sister that you get along with more than the sister that you might not get along with. Your sister's kids or your brother's kids, your nieces and nephews, which some you might be closer to than others. You think about your parents. And then when you think about your parents, you have your mom's side of the family as well as your dad's side of the family. Those people, the aunts and uncles, they have their kids. Those become your cousins. And then you go up to grandparents on mom's side and dad's side. So when I'm taking a 3-generation pedigree, if I think of you here, I have 1 generation down here, 1 generation here, and 1 generation here. So ideally, I would like to see at least 3 generations of pedigree, 3 generations throughout the family history to see if I can see any cancers at least 3 steps from you. So when we're thinking of, is that cancer close enough to me? Is it too far away? If you can think about them on a map like this and you can count 3 steps to you, they're close enough to count. They're close enough to mention to your doctor. When we take this pedigree, we don't draw obviously little pictures. We draw women as circles and men as squares, and always the women are to the right because women are always right, and that's easy to remember. And so we will take that family history, that rich family history that you know, the likes and dislikes, and the people that you're closer to and the people that might be estranged. And I'm going to try to simplify it into this, which is our 3-generation pedigree. And so when I am encouraging people to take good family histories, there's a couple of things that I always want to focus on. And so first, it's getting that relation. A lot of times we talk about family members that are our aunts our aunts, depending on how you pronounce it, right? They're close relatives to us. They grew up with us, but they're related through marriage, or they're actually not fully blood relatives. They may be adopted into the family, and they might be just as close as family. So one thing that I always make sure to ask a point of is making sure that when we're taking a family history, we recognize how that person who had cancer is related to us. A really good example here is in this picture. If you think about this 39-year-old patient, the arrow always points to the patient. She will mention, of course, that her mother had breast cancer at 40, but she may mention that her cousin had breast cancer at 45. And if I was thinking that that was her cousin, I would expect it to be one of these people's kids, and they would have belonged right here. But this person who had breast cancer is actually her mother's cousin. That's her first cousin once removed. And so what might have been communicated to you by your parents as your cousin or your aunt or your great aunt might not be as closely related. They might have been a half sister versus a full sister. And those are all things to help ask the family history and try to clarify. Where did the cancer start? I think the nature of cancer is that we tend to name cancers colloquially within family regarding the cancer that took the person's life. So it's not uncommon for me as a genetic counselor to encounter people that say, well, my grandmother died of lung cancer, but upon further probing, we actually learned that the lung cancer actually didn't start in the lungs, but it was actually breast cancer that spread to the lungs, because the lungs is a common place for breast cancer to spread. Or it wasn't originally brain cancer, it was, say, pancreatic cancer that spread to the brain. And so we always want to, when we're talking with our physicians, we always want to say, to the best of our knowledge, where did that cancer start? Now, sometimes we don't know. Sometimes cancer is caught so late stage that we don't know where it started. But I encourage you, whenever possible, when speaking with family members, to try to ask, where did that cancer start? Did it start in the breast? Did it definitely occur in one breast and then come back? Or did that person have breast cancer on one side of the breast and then have breast cancer on the other side of the breast? So therefore, that's 2 breast cancers. We always want to differentiate a primary cancer, a cancer that started newly, from a recurrence. The analogy that I think makes it make sense here is A primary is like a fire starting, and your oncologist, your radiation oncologist, your surgical oncologist, they will all be focused on doing everything they can to put that fire out, whether that's chemo or radiation or surgery. They will use all their tools at their disposal to put that fire out and then monitor you to make sure that that fire doesn't ever reignite, that those embers stay dormant and that they never ever reignite. And when we talk about most people getting cancer more than once, the worry is, was that cancer, did those embers catch some oxygen and reignite? With hereditary cancer, though, that's not really as much of a worry. The worry is that you might beat that cancer dead and gone, but then develop a second cancer, maybe another part of the body. So it would be not that the breast cancer had spread to the lungs, but that a woman developed breast cancer, beat that, and then later went on to develop ovarian cancer. 2 primary cancers, 2 lightning strikes, so to speak. And that makes us more worried that cancer is hereditary because we don't have a good answer as to why lightning keeps striking. And finally, as I said a little bit earlier, the younger you are, the more concerned we are that it's hereditary. So what I say is, as you're seeing here in this bar graph, which shows cancer onset from the years 2013 to 2017 as just a snippet, in general, the longer we live, the higher our relative risk of cancer. And that really is just a function of age. As we age, our risk to develop cancer simply increases because of the age. So when we see cancers in family occurring, if this bar graph you're seeing here were shifted to the left a little bit and the cancers were onset at a much younger age, that is more suggestive that what we're looking at may be hereditary cancer. And so when I'm asking people to learn about their family histories, I don't need exact ages. I'm not going to change what I say if it was 75 versus 78 years old at diagnosis. But as much as possible, ask family members, get an idea, was it in the 70s? Was it in the 60s? My general rule is ballparks are safe in my room. If to the best of your knowledge, it was in the 50s or the 60s or the 70s, that's a really helpful frame point to be able to reference. What are a few pointers? Well, first, dad's side does matter, especially with breast cancer. There was a period of time where doctors were telling patients, oh, I only want to hear about mom's side of the family. We don't care about dad's side. And we've come a long way since back then. We now know that 50% of mutations that predispose to breast cancer come from a woman's dad. And so it might just be either you don't ask about that family history because you didn't think it mattered, or in general, men are not perhaps as forthcoming with their family history as women are. So statistically, when I speak to my patients, I'm far more likely to have a much fuller family history from their mom's side than I am from their dad's side. It's important to ask that person. Even if it's not your dad who's the best historian, if your dad's not the best person to ask these questions, identify that paternal aunt. Identify that person in your family who's the glue. Every family has that glue, that person who's kind of the record keeper, the person who knows the stuff, and go to that person and ask them, how old was grandma when she passed away? And do we really know what kind of cancer that might have been that she had? It's really important to not limit your questions to breast cancer. Sure, it might be very easy to write off a person who smoked a lot and got lung cancer, but still it is important to mention those cancers, even if they're not readily suggestive of a hereditary cancer syndrome. If somebody died of lung cancer in their 40s, then they weren't alive later on to get breast cancer. It's important to take a full family history and get a general idea of how old people were when they passed away, because how old people made it to matters as far as whether or not they developed cancer or not. There are certain cancers that we link with breast cancer that we are more suspicious of when we see them. So things like ovarian cancer or pancreatic cancer or prostate cancer in men. These are all cancers that can go hand in hand with breast cancer, and they can increase my concern that the likelihood that I'm going to see a mutation. And finally, unknown does not equal normal. It's really easy to think, well, if I don't know anything about my family history, what I don't know can't hurt me. And unfortunately, that's not really the case when it comes to family history. Again, I go back to the statement that hereditary cancer is thankfully quite rare. About 10% of cancers are hereditary. But please don't take an absence of information about an estranged family member to assume that that person is alive and well and has not developed cancer. It's important to communicate to your physicians not only who has had cancer, but whether or not you are close enough in contact with these people that you would know if they had developed cancer. That's a really important distinction. This cannot possibly be comprehensive, but just to give you guys a quick sort of what are the red flags? What are the things that spark concern for hereditary cancer in a general sense? Well, anytime 3 of the same cancer occurs on the same side of the family, so either you and your siblings and mom's side or you and your siblings and dad's side, whether or not 3 of the same type of cancer occur is a risk factor. So if you can think of a specific type of cancer that has occurred 3 separate instances in your family, that's a reason to tell your primary care or OBGYN. Any diagnosis of cancer under the age of 50 warrants a conversation with your doctor to figure out why that happened so young and whether or not that warrants genetic testing. Rare cancers. So pancreatic cancer is rare, ovarian cancer is rare, and I cannot possibly have a conversation and not mention TNBC, which stands for triple negative breast cancer. Triple negative breast cancer is a type of breast cancer that it tends to be more aggressive than estrogen-driven breast cancers. It oftentimes needs chemotherapy in order to attack it. And it is much more likely in women of color. And so when we see triple negative breast cancer, it doesn't matter if the woman is 60, 70, 80, or 90. Having any triple negative breast cancer in the family is a reason to consider genetic testing. And if in doubt, even if in the slightest amount of doubt, you are in your best hands if you go to your physician. Have that working great relationship with your doctor who you're going to be able to say, these are the concerns. I did my fact-finding mission. This is what I found. Let me show you what I've brought, and you can tell me what questions you have and give me pointers about what additional information might be helpful for you. You have the primary care and the OBGYN, which are both well-versed in genetics, and they know when to refer for genetic counseling. Lots of primary cares and OBGYNs now are doing this testing on their own. But I still want to talk to you about what do we do in genetic counseling. So if you were to get genetic counseling, you might look at this hypothetical tree here that I drew and say, okay, well, if this woman is thinking about genetic testing and she herself has a mom who had breast cancer at only the age of 48, a grandma who had breast cancer at 42, and an aunt who had ovarian cancer, you might say to yourself, yeah, you know what? She certainly sounds like she would benefit from genetic testing. And you're right, she probably would. But when we do genetic counseling, we're always going to ask ourselves the question, who is the best to test? What I mean by best to test is when I look at this full family history of people, and we think about genetic testing as costing several $1,000s per person, we could test this person, this person, this person, this person, and add up to thousands and thousands of dollars. Or we can do this in a strategic way to make sure that if there is a cause, we get to it quickly and we get to informative information. So let me explain that a little bit better by saying this. If I simplify the tree down to just the patient and her mom is someone she talks to every night. She's very close to. Her mom would do anything for her. Her breast cancer was a while ago. She's closed that chapter in her life, and she doesn't like to think about the experience of having breast cancer. But this mom would do anything for her daughter. If I met with this daughter, I would say, if you felt comfortable with it, can you please talk to your mother and see if she'd be willing to do genetic testing? If she had testing a long time ago, would she be willing to update that genetic testing to make sure she's had the most comprehensive, up-to-date test that's available? I'll try to explain that a little bit with this visual here, this analogy. So if I am meeting a person who personally has had cancer, we want to do the biggest, best test that we can possibly do. We want to do the most comprehensive analysis. So in my analogy, think about that as asking the laboratory to read an encyclopedia set. Right now, the encyclopedia set that we use has 48 books in it. So we're asking the lab to read 48 books, cover to cover, page by page, looking for a spelling error. That's the mutation. If I find a mutation, then I go into the daughter's report and I know exactly what word is spelled wrong. You guys know how it looks in Word, the little squiggly red line at the bottom. You know exactly what word is spelled wrong. You know exactly where to find it. And you become very, very dichotomous. Either it's broken or it's not broken. It's there or it's not there. This makes a really big difference in what this woman's ultimate risk of cancer is. If she is negative for the mutation that caused her mom's breast cancer, she can rest assured her risk to get cancer is at or near the general population risk. But if mom came back negative and my patient comes back negative, how reassured should you be for a test that's negative in your mom who's had breast cancer? You shouldn't be too reassured because look, your mom, despite being negative, still developed breast cancer. So I fully recognize that there's plenty of times where mom is or the affected relative is no longer with us, or they're estranged, or they've truly closed that chapter in their life, and it would be far too stressful for them to come back to a cancer center to consider genetic testing. But whenever possible, we try to start that testing with a family member who's had cancer so that we can throw the book at them, so to speak, see if we can test for anything under the sun. And if we can find an answer in an affected family member, that leads to very informative, targeted testing for their unaffected relatives. So when we meet for genetic counseling, we'll take this family tree and we'll try to establish a mutual agenda. In other words, for most people that do genetic testing or genetic counseling, this is the first time they've sat down with a provider for at least an hour-long session to discuss what the pros and cons of doing testing are. And so I try to give people a heads up of, this is going to be a 60-minute session typically, and this is what we're going to cover. And please interrupt me if you have questions. We'll obtain a medical history. So we'll try to ask the person, have they ever had cancer? How old were they when they had cancer? Review the actual pathology reports. We'll obtain a family history, of course, and we'll perform a risk assessment. There are lots of tools available to us to be able to say, is it a 5%? Is it 10%? What's the actual likelihood that you're going to carry a mutation? We'll discuss the pros and cons of genetic testing, and it's not without risk. Genetic testing can be stressful. Genetic testing can tell us things that perhaps we might wish we didn't know. And especially when it comes to discrimination, we talk about the idea that getting a genetic test that can predict your higher likelihood to get cancer, there are certain steps we need to take to prioritize your privacy before moving forward with genetic testing, that at a genetic counseling session, we would go through those in detail, talking about, you should know that this won't affect your ability to get health insurance, and your job, as long as you work for an employer that has more than 15 employees, can't use this information against you. But you might want to know that something like a life insurance might ask about this genetic testing. So some ways to avoid that are to go get life insurance first before you've had the testing, and then get the testing done after you've obtained the life insurance, so you can answer them truthfully, I've not had genetic testing yet. Finally, my job as a non-physician, I'm not a doctor, I don't play one on TV. I don't tell you, I don't recommend, I'm not allowed to have a clinical instinct. I am allowed to tell you, these are the pros, these are the cons. Let's work together to come up with what's the best fit for you. Is this a good fit for you? What do you think you'd do with this information? What do you think you'd struggle with about what this information could show? Is this information that you and your family members would find valuable? All of this is either done in an in-person, face-to-face, or now, thanks to COVID, a lot of insurances do cover a telehealth visit. So a lot of times we'd be able to do this from the comfort of your home. What does the future look like? Well, I just want to give you guys an idea, especially I saw in the poll in the beginning, a good number of you guys had a beginning working familiarity with genetic testing. Perhaps some of you guys have personally had genetic testing before. What does the future look like? Well, let me lay this out for you. Imagine here on your left, these are things that are the lowest risk of cancer and things that are the highest risk of cancer. Here are things that are very common in the population, and over here are things that are very rare. Well, first we discovered BRCA1 and BRCA2 up here. And then we discovered these additional genes here. And finally, in gray, we discovered these genes here that have a more medium risk of cancer. So right now, what you're seeing here on the screen, these are the genes that more or less most laboratories are offering testing for right now. This is our current testing as of 2023. All three of these. Now, what do we look like? What does it look like in the future? Well, we know that there are these SNPs. Why it's doing this here, these little dots here. And I put them as dots because it's not important for you to know their names, because individually, none of these work alone. SNPs just stands for a single nucleotide polymorphism. Think about it as a marker. It's not a mutation. It's not the gene being broken, but it's like a spelling difference. It's not a spelling error. It's a spelling difference. And these differences don't work alone. Maybe one single SNP might take your risk of breast cancer from the average number of 12 up to 13. That's not enough to report. That's not enough to test you for. But if in your family there are 10 of these SNPs, whereas the average family only has 1 or 2 of these SNPs, the SNPs may actually be able to explain what currently available genetic testing has not done so yet. And so when we're talking about genes working in concert with one another, it's not as simple as black or white, you have or you don't, positive or negative. They use what's called a polygenic risk score. A polygenic risk score is taking how many SNPs, what the family history is, using bioinformatics to come up with an assessment, a likelihood, a percentage probability that you will develop breast cancer. This testing is being done on a research basis now. The National Comprehensive Cancer Network says it's not ready for prime time yet, but we're working on it and it's coming down the pike shortly. So not to tease something that doesn't quite exist yet, this is what we're trying to get at. If we've got good testing for hereditary cancer, the goal is to help these people who have a family history, but it's not as bad as BRCA. It's not as explained as BRCA1 and BRCA2, but there is still a somewhat increased risk. And how do we quantify that? Is that high enough to need breast MRIs, or is it not high enough to need breast MRIs? This can help us do that, because we know that some cancers are caused by the environment and some cancers are caused by genetics, but the part that we're missing in the picture is that modest increase of where genes and environment interact. So I allude to the idea that there's this test coming down the road, but what could be done right now? I want you to know that there is a thing called a Tyrer-Cuzick, and sometimes the squeaky wheel gets the grease. So I always want to encourage you to ask your primary care doctor, ask your OBGYN, given my family history of breast cancer, would you calculate my Tyrer-Cuzick? And this is an assessment model that can be done by a physician. It's available online. What you answer are questions about yourself, like how tall are you and how much do you weigh and how old were you when you had your first period? You answer questions about your mom's side family history and your dad's side family history. And that's not just who had cancer, but it's who of how many. You can imagine if you have one aunt with breast cancer and your mom only had one sister versus you have one aunt with breast cancer and your mom had 8 sisters. Those are 2 very different risks, right? The Tyrer-Cuzick model can take all that information in. You build a little preliminary family tree and you plug in who's had testing, who hasn't had testing, how old people were. You hit calculate and it'll print out this actual likelihood of developing breast cancer. And so in this person's hypothetical printout, the blue is the average person's risk. And so that risk gets higher and higher as we age. But this woman's risk is significantly off that chart. So for her, given that at this period of time, let's say we're seeing her at the age of 72, her risk is 18, but her lifetime risk is 22.5. So that tells me that she might benefit from doing breast MRIs. And so a lot of insurances won't pay for breast MRIs unless there's some demonstrated risk of 20% or higher. So it's important to know that tools like this exist. And even if you don't think that you have BRCA, even if family members have been tested and they're negative for BRCA, this is still a tool that's available to women that have not personally had breast cancer. It can't be run, unfortunately, on someone who's already had breast cancer, but it can be run on anyone who has a family history of breast cancer and they themselves have not personally had breast cancer. The final thing that I want to close on is the existence of DTC testing, or direct-to-consumer testing. I talk about this because the holidays are coming up and this is a popular holiday gift. It's things like Ancestry.com or 23andMe. These are tests that are becoming more and more widely available, and especially in the holiday time, they go on sale for sometimes as little as $50 to $100. So it becomes a very, a reasonable Christmas gift. And so when we think about this testing, I'm always asked the question, like, as a genetic counselor, would you recommend that I do this? And I don't ever recommend against something like this. If it's something that you're just doing for fun, if it's something that you're doing to learn about your ancestry or to connect to family members, it's something that's out there. My only agenda here is to make sure that nobody confuses it with medical grade testing. They're apples and oranges. So in this analogy, let me see if I can try to explain here. In medical grade testing, if we're thinking again about my book analogy, we're reading the instructions on how to fight cancer. Medical grade testing reads each individual letter by letter, to make sure that there's no spelling error. A direct consumer test like 23andMe covers up all the other letters besides the one most common error and says, is it broken or not? Is it yes or no? So you can imagine if it's covering up vast majority of the page and only looking at one letter, it very well can and does miss things. So you really can't do a 23andMe and expect that to replace a medical grade test. If you are genuinely concerned about cardiovascular, neurological, cancer genetics, your best approach is to speak with a physician and discuss medical grade genetic testing. There are pros of tests like this. It does make more and more people aware that hereditary genes do play a role in our disease processes and health. And it can help you establish appropriate relatedness. So if perhaps your paternal side is more estranged, but you're able to get in touch with some communicative family members through something like a 23andMe, that's great. If you can find those people that are looking to reach out to relatives, this is a great way to identify people. It does provide ancestry data. It's sort of hard to verify that, to know exactly, are you 20% this, 40% that, but it sometimes can be helpful because I do encounter people that don't realize that they're coming from high-risk ancestries, such as Ashkenazi Jewish ancestry, until they do a test like this. It can increase feelings of empowerment. So the idea that you can take ownership of your genetics is something that does encourage people to eat better and exercise more. It does involve you in research. So these tools, part of the reason why they are the low cost that they are is because they are putting them in databases for drug development and for increasing medical grade testing. And finally, it is relatively easy to use because it can be done at the comfort of your home. But just to illustrate one example is 23andMe is one widely available test, and it does offer the option of doing BRCA1 and BRCA2 testing. And as of up until last week, it was only doing 3 mutations. And those 3 mutations occurred almost exclusively in Ashkenazi Jewish individuals. So if you were not a member of the Ashkenazi Jewish ethnic group, it wasn't even genetic testing for you. It wouldn't work at all. Starting last week, as recently as last week, again, ramping up for the holiday season, they released the update to the test that now allows you to do 44 different variants. And those are variants across all different races and ethnicities. So there is a very real possibility that more people will identify whether or not they're BRCA1 or BRCA2 positive through a test like 23andMe. But if you have the 45th most common mutation, this test will miss it. And so the worry here is that if people don't realize it's such a limited test, they might think, oh, that's good enough, I'm okay, and think that that's enough. Where if there is truly a family history of cancer, we want to do a full analysis. So in closing, what are the take homes? If you took nothing else from me, what would I love for you to take? Hereditary cancer is thankfully rare. Like I said, only about 10% of cancers. So despite how rare it is still very important to know if you belong to that group. And the best way to identify whether or not you're in that group is to take a good family history. Learn everything that you can from the people in your family you know are the keepers of the secrets, and bring that information to your primary care doctors and your OBGYNs. If appropriate, your doctor may refer you to genetic counseling, and that's a tool that'll help you learn about the pros and the cons of genetic testing and help you make a decision that's right for you and your family. And finally, not all genetic testing is the same. There are tests that are much more thorough and much more accurate than other tests, so speaking with a professional is your best route. I want to thank everybody for their time and attention. Thanks.
Kendra, fantastic presentation. Snapping my fingers, clapping my hands. Can the audience join me virtually clapping your hands? You did an awesome job of breaking down such complicated topics. I learned a lot of new information and better tips for discussing with my patients, family members, and community members. Kendra, the audience is giving you a big shout out. So thank you.
Thank you, everybody. Thank you so much.
Excellent. It is now time for the Q&A portion of today's webinar. We have a few questions already lined up, and I'm going to ask that each of you, if you have questions, please put them in a Q&A box, and we will do our best to answer them tonight, if not tonight, in the future as well. So we will start with a few questions, Kendra.
Okay.
The first question is, what if your family is super private about their family history, medical history? Do you have any tips for asking? And also, are you aware of any surveys or questionnaires that can be used to collect this information from your family?
That's a good question. So probably the easier to answer of those two is I don't know of any surveys other than just simply what we use as our family history questionnaire. So when you have an appointment with genetic counseling, we will ask you to fill out a questionnaire, and it'll go through each, both grandparents on both sides, all the aunts, all the uncles, all the cousins, and it'll just go through that. And that is a really good checklist. So if anybody would want access to that, I'd be more than happy to share that with the group. So even if, if you just make it a personal agenda this coming Thanksgiving and holiday season, to ask those questions and use this as a checkbox of all the things you need to know, I'd be more than happy to share that. But to the harder question of the two questions, when people are private, and I think that family histories are both the best thing that we're blessed with and also sometimes the hardest challenges that we sometimes have to overcome. And you have to sometimes pick your battles. You have to sometimes say, if this is going to cause more heartache or headache between the existing relationships between this relative and that relative by bringing up these things, it is something that you have to be strategic about. Talk to the family members that might know more, or everybody knows, hey, these two people don't get along in the family, but this person gets along with that person, so I'm going to ask that person to talk to this person. But when you're not sure, being upfront with a primary care doctor or an OBGYN about the limitations of your knowledge and your family history can really help that doctor weigh, okay, is this a very reassuringly negative family history or a somewhat less reassuring family history? I'm so grateful to say that while I do not widespread recommend genetic testing to everyone, this is not something that everybody needs. We are very fortunate that the cost is going down. So there's certain criteria that need to be met. There's certain amounts of cancer that need to be met in order for most insurance companies to pay for genetic testing. But if you are in a kind of stuck between a rock and a hard place and you're not able to get that exact age that grandma was or exactly how many people had a certain cancer, you may elect to do testing at a small out-of-pocket price. Right now, that price is $250. And I don't say that is sometimes a very cost prohibitive cost for many people, but given that this test used to run several $1,000s, it has come down significantly.
Excellent. Thank you. I never thought of that before. We always ask patients, tell me about your family history. Cancer, no. Diabetes, no. But rarely will someone say, I don't know. And
right.
It's a tip that, thank you, I encourage my patients. I'm going to make sure that I really delve in to make sure that they're aware of their family history. And I'm hoping that everyone today will make sure that they're encouraging people to be open and honest with their docs.
Unknown is not negative, right?
Yes. You already asked one of the answer. The next question, does insurance cover genetic testing? So I'm so happy that the price for many of these tests are now a lot more easier to obtain for the general population. The next question was, once you get genetic testing, how often should you have it repeated?
That's a great question. Love that. Thank you. So in general, if I've met with a patient, one of my closing remarks is always, let's be pen pals. As I'm sure you guys all are, we're stuck to our computers. I'm on email all the time. I love receiving emails from patients, and I'd usually say, shoot me an email just to check in maybe every 1 to 2 years. Not to say that you would need another test in 1 to 2 years, but it warrants checking in with whoever did your testing about the state of that testing at most every 2 years. Why? Because it's like an iPhone. There's a new one every year. The test gets bigger and bigger. Your family history changes, right? What we order is informed by what's present in the family, and family histories change with time. And finally, sometimes testing results come back with something that's not quite positive, not quite negative, called a variant of uncertain significance. And that's sort of like saying, I see a difference, but the jury's still out what it means. Checking back in with the genetics professional every 1 to 2 years ensures that we can do another query to say, does anybody call your differences bad? Does anybody call those differences harmful? Because if so, we need to start reassessing that risk based on this new available data.
Thank you. Kendra, everyone wants to be your new best friend. But my question
I'm looking for best friends.
How should someone go about inquiring about genetic testing? Should they email you first, come and see you first, or should they talk to their PCP or their OB-GYN? How do they go about inquiring about genetic testing?
So if you don't mind me being crass, I feel like genetic counseling or genetic testing is like picking your nose. And if you're going to pick your nose, you need to have a plan for what you're going to do with what you find in there. And so if I want to be your best friend, and if you have questions that'll help you get into the right place, please do not hesitate to reach out to me. But I want you to have a plan for what you're going to do if you find a booger in there. Okay. And that is your primary care doctor and your OBGYN. I have a 1 or I meet with my patients every 1 to 2 years. A primary care doctor is a relationship. I feel like you probably know this very well. You're very used to this notion of, we want to make sure that it's not just giving you information that you can feel crippled by. You want to get information and then a plan of attack. If you need breast MRIs, how do we get those prior authorized by insurance? If you need colonoscopies more often, who's going to write the prescription for that? So what we want to do is we want to make sure that you at least talk to your OBGYN, talk to your primary care doctor. Let them know that this is something that you've been thinking. Let them know that this is a concern that you have. But if it's been, if it's been a bit since you met with a primary care doctor, or you've been meaning to get a new primary care doctor or something, you can make a self-referral. But I always feel very strongly that information without a plan of attack afterwards is just information for information's sake. And the best resource we have at attacking these risks is to have a good, strong relationship with a primary care doctor and or an OBGYN.
Excellent. Thank you. There are a few people inquiring about family history of BRCA and potentially family history of breast cancer, but individuals testing negative for BRCA. In particular, one person said that their mom tested negative for BRCA, but it was more than 8 years ago. And they were inquiring if it's worth them also being tested for it now.
Yeah. So, especially if we have good reason to believe that the relative only had BRCA1 and BRCA2, we do now always order more than BRCA1 and BRCA2. And that's because we've learned that while BRCA1 and BRCA2 do still represent some of the highest risks and some of the most common positives that we'll see, they're not the full picture. We know that there are genes like PALB2, which stands for partner and localizer of BRCA2, or ATM, or CHEK2. These are all genes that we didn't know how to test for as much as 8 years ago, and that we now do know how to test for. So ideally, we would update mom's testing if she was still willing to do so. But if she's not interested and she's not looking to do that, then we'd be more than happy to see someone based on a family history of that.
Excellent. There are a few other questions in the chat about the direct-to-consumer testing.
Yeah.
There's a question about, is it common to do testing for colon cancer? And then the other one is there a test available for sickle cell anemia?
Yes. So 23andMe will look for they'll look for carrier status for sickle cell anemia, and then by doing that carrier status can identify people that do have sickle cell. That testing is relatively good on 23andMe because it's not a complicated test. 23andMe can do that one, and there's only one specific sickle cell mutation. So 23andMe should identify that. That being said, it doesn't look for things other than sickle cell. So if you've ever heard of hemoglobin C or beta thalassemia, which can interact quite a bit with sickle cell, you would want to do a medical grade test, especially if you were reproductive age and thinking about this in relation to a pregnancy. In relation to colon cancer, 23andMe does do one gene called MUTYH, MUTYH. That is one gene associated with an increased risk of colon cancer, but it's not even the highest risk gene, and it wouldn't even be my first thought with a family history of colon cancer. So if a person truly has a family history of early onset or multiple colon cancers, genetic testing and a medical grade standpoint is the way to go.
Excellent. Along those lines, are you aware of any over-the-counter testing that can test for BRCA or any of the breast cancer mutations?
So the only ones right now that offer direct to consumer, so direct to a patient without going through a physician of some sort, is 23andMe, and that's for those 44 mutations in BRCA1 and BRCA2. There is a kind of hybrid between direct-to-consumer testing and medical grade testing, which is called patient-directed testing, where you reach out to the laboratory and you say, I'm interested in this. And then the laboratory has their own employed physicians which say, okay, we'll order this for you. And then they order the medical grade testing. That is available, especially if you have a family member that lives in the middle of nowhere, right? Like it would be a huge burden to ask your grandmother to travel from the very small area that she lives in to a major city to see a doctor for this. They might do this patient-directed genetic testing. The only limitation of doing that is that that patient-directed testing, they don't look at your medical record. They don't have access to your mammogram reports. They don't have access to your colonoscopy history. So when they're not given the full picture, they might not order the correct test. When I meet with the patient, before I even lay eyes on them, I'm looking through their medical record, reading their mammograms, reading their colonoscopies, and making sure that I'm ordering the correct test. If the patient gets to pick based on what they're interested in, they might not pick the large enough or the appropriate test.
Excellent. And the last question for tonight, there's a lot of interest in the testing, but also concern about what do I do with the results? And there was also a question about will insurance cover preventative treatment and surgery if your risk is detected for being higher with this test?
Yeah, and so insurance is required to use, so the National Comprehensive Cancer Network, which is a group of a consortium of physicians that say, what are the rules with respect to increased risk of cancer and how to treat cancers? Mutations that are a high enough risk do grant with them coverage of insurance for the bilateral mastectomy. And if you choose the bilateral mastectomy, the reconstruction with either autologous tissue, which means like belly fat, or with implants to build the breast after you have the bilateral mastectomy. So those are all covered as part of one package that insurance has to pay for when you are positive. But I understand and really do echo concerns that this is not something for the faint of heart. Genetic testing is something that can give information that can be enormously valuable. If it can be the reason why your daughter gets her mammogram starting in her 30s and not waiting until her 40s, all the better. That's the goal. But if it's going to be the reason why every time you have an ache or pain, it feels like, okay, well, this is pancreatic cancer. It's coming for me now. We always want to make sure that we balance the benefit with the cost. And so that's why I thoroughly believe in this idea that if this was a no-brainer, I wouldn't have a profession. There wouldn't be a career for me, because this is a good fit for some and this is not a good fit for others. But you don't need to do genetic testing in order to see if you qualify for breast MRIs. You don't need to do genetic testing in order to determine whether or not you meet criteria to do testing in the first place. So there is value, I believe, in genetic counseling, even if your end result is not to do the testing, but to walk out with a better assessment of what your risks are.
Kendra, what a great way to end tonight's webinar. Thank you so very much for the wealth of information that you have shared with us. I feel so much more informed today. Our audience is giving you kudos, shout out. We look forward to continue to work with you, partnering with you in the future. If you have any additional resources, we would love to share them with our participants. If there's any way that we can support your efforts and initiatives, please let us know. But we are so appreciative of you coming out tonight and joining us for tonight's webinar. Thank you, Kendra, from the bottom of my heart. Thank you. All righty. On behalf of the Wilmington Alumni Chapter of Delta Sigma Theta, we are so excited that you decided to spend your night with us and learn more about genetic testing. We hope that you learned some valuable information and gain some new resources that you can share with your family and network. It is our hope that we can collectively work together to reduce breast cancer in our communities. Prior to logging off, please be sure to complete the post survey. We would love to get your feedback about today's webinar and recommendations for future webinars and events. Please be sure to follow us on social media to stay informed about our future events, community service initiatives, and other health-related webinars. Thank you again for tuning in tonight. Be blessed, stay well, and have a great evening. Thank you.